I'm going to talk a little bit differently today. I'm going to talk about a little more generally. And the reason being that we just passed our health reform law in 2012. So I will talk a little bit about what the law says and then how that lends itself to our Medicaid program and where we're going from here. And we don't quite know, frankly, if this is going to work or not, but it's our best guess, just to make sure everyone is still awake. I think this was Dave and I coming in last night from the bar around 1 o'clock in the morning, right, Dave? He parties like he's from Louisiana, because he is. So this is what's happening in Massachusetts. $66 billion is what we spent last year. By 2021, we'd be at 21% of our GDP or our GSP, obviously squeezing out everything else. Cost for 2013 would be at 7.5%. As you know, everything else is growing at 3.9 and predicted next year to grow at 2.9. So this is the problem. You can't have double-digit increases in healthcare while everything else is growing lower than the rate of inflation. This is our state, but your state is exactly the same. Senator Alexander talked about this morning. What have you squeezed out? If you care about the environment, if you care about public safety, if you care about education, if you care about mental health or human services or local aid, you have cut it since 1990. We've raised $1 billion a year in our budget since 1990 to make up for the costs in healthcare. We spent $14.5 billion in the state budget in healthcare out of our $30 billion budget. It's absolutely unsustainable, and every other area of our budget has been cut because of it. So how do we engage the consumers in this? We talked a little bit about this last night. Consumers just don't understand this, nor do they want to, because they've never had to, right? I mean, it's an open bar. Everybody's drinking and no one knows who's paying. That ultimately is what our health insurance system has developed. So we needed to look at how to move some of the leverage back towards the patient and the physician and away from the payer and the large providers. The first thing we looked at, the banks figured this out 15 years ago. And Deborah and I were at a great conference in DC 2 weeks ago, Health Data Palooza, and they talked about how banks are saving 30% of their administrative costs now that 40% of their folks are on online banking. Right? We can get money in the lobby, we can get money anywhere in the world, but if something happens to us here today, they can't find out who we are. They don't know our medical history, they don't know anything about us. So for the first time, we'll be the first state, I think, that will be interoperable by 2017. Anywhere you present, your health record will be available to you, and then in real time, we'll go back to your doctor. Kelly and I talked about this a little bit last night as to does your doctor get notified, or is there a buzzer system? Ultimately, the technology is only as good as whether or not you are using it. But for the first time, you'll be able to know what's your record. It's so personal to us, yet it's the one thing that we all seem to shy away from. And there's a cost savings there, and there's a quality savings there, because you don't get over-tested. You don't show up at the emergency room and you don't run that car wash of tests that they do when you go in, because all of them are reimbursable. The next thing we looked at was disclosure and transparency. Healthcare, the only system where you have no idea what the costs are, the quality are, or the risks of anything that's being done to you. You don't know if at a CAT scan at 240 times the radiation is going to show any more than an X-ray or an MRI. You don't know that. But you self-diagnose because you see this great commercial where a guy's running through the fields and he looks so happy, and you go to your doctor and say, I want that pill, or I want that test, or I want this. And because of med-mal, which I'll get to in a minute, oftentimes doctors say yes. They've been in a position where the system has enabled them to have to protect themselves first in many ways. Disclosure and transparency allows doctors to use information to help their patients. So for the first time, doctors in real time will know what's happening and what the costs are of something that they're asking their patient to do. For instance, Leahy Clinic in Burlington, Massachusetts. An MRI at Leahy Clinic is $1,800 on a Sunday afternoon. Down the street at Shields MRI, it's $575. It's a huge savings. It's a huge difference, especially a huge difference if all of us are paying for it for our uninsured population. The next thing we looked at, and this is a big problem we have in our Medicaid, and I'm not sure what's happening in other states, is the churning of it. Right? So in terms of administrative simplification, you should have to sign up once. Government should be able to figure out what system pays you, whether it's your exchange, your connector, your Medicaid, your dual. We've never quite figured that out. So people get knocked off the rolls, and then they have to be put back on. And it costs an incredible amount of time and money. Administrative simplification says on the Medicaid program, you sign up once. And for the commercial payers, why every time that you go into a doctor's office are you handed that same damn clipboard that you have fixed out every single time again? So administrative simplification works hand in glove with an EMR, right? We shouldn't have to do that all the time. That drives up the cost of healthcare, and it's something that is incredibly inefficient. Access to care is a big problem for us even. We have some rural areas of Massachusetts, and I know in some of the states that are here, it's even a bigger problem. So we had to increase the scope of practice for nurse practitioners and physician assistants. ultimately what we were finding is those that were presenting in an emergency room were doing so because they either couldn't get an appointment, they didn't have a doctor, or their clinic or their health center was closed. So we incented places to stay open after hours, as well as required each patient to have selected somebody or be selected for them, somebody that's their quarterback, somebody responsible for their health care, whether it be a primary care physician, a physician's assistant, or a nurse practitioner. Conventional medicine says take aspirin. In the absence of tort reform, defensive medicine says MRI and CAT scan. So Med-Mal was costing us about 10%. Now 10% of $66 billion is an awful lot of money. It's an awful lot of teachers. So we did what has been widely successful in Michigan and used the disclosure and apology approach. And we are seeing some success with this already. It is incredibly important that a doctor feels comfortable talking to their patient about what happens and not worrying about their legal department. And that is oftentimes what happens with some of our large providers. They are taught from the moment they walk through the door, don't tell the patient anything. This allows the patient and their doctor to be able to have a real conversation. That conversation isn't admissible. It takes no other rights away from the patient. Everything is still, they are still fully liable if there's negligence, but it allows for a cooling off period so that conversation can take place between the doctor and their patient. Representative Lewis is here from Massachusetts, who's worked extensively on this. One of the things that we have never focused on in this country is prevention. We're just not good at it. The only thing we ever did with any success was smoking cessation. It was partly a number of lawsuits. It was partly that we began to shame people so much that you have to hide under the table if you want to have a cigarette. And we had enough money to be able to handle this in a way that made sense for folks and began to reduce the rates of smoking. Now, some would argue, we had this discussion last night, that as we get healthier, we actually live longer, which drives up the cost of healthcare. So we actually want some people to go back outside, keep smoking, and die. It'd be so much simpler for us. But we set up a prevention and wellness trust that really allows us to get real dollars into the community. We set aside, I don't know, $65 million, I think, initially, to try to have some real impact. You know, when you look at what some of the things that other countries are doing, you look at Scotland, for example. Scotland pays, they give you a check. They pay you if you have a body mass index lower than a certain amount. Now, I wouldn't get that check this year, but if I lived in Scotland, it may be something that I would work towards. We don't do that here. We pay you to be sick. We don't pay you to be healthy. Payment reform. Don Berwick, as many of you know, former director of CMS, he said this just yesterday, 2 days ago in Boston. We are addicted to volume. The more you make, the more you do, the more you make. It's not good for patients. So what we did with payment reform, and I consider everything before this really the low-hanging fruit, really the things that everyone agreed on: transparency, disclosure, EMRs. But when you get into payment is where you really get some of the difficult arguments. Now, what we did was a little bit different. You know, everyone talks about ACOs. That is the alphabet du jour, right? Those are the words of the day. Nobody really knows if that will work, right? But here's what we do know. We know that fee-for-service medicine doesn't work. You read any of the books by Atul Gawande, who does a great job with this. He likens this to if you were paying fee-for-service for your plumber, you'd have 200 toilets in your house. Or if you're paying it for your electrician, you'd have 500 electrical outlets. When you pay each individual service, it generally costs more, as opposed to looking at our community in a holistic way and how to keep, what does it cost to keep our patients healthy, should be the question. Not how much can we charge them to find out what's wrong. So what we said in Massachusetts is fee-for-service is illegal. You cannot do it. But we're not telling you that you have to have an ACO. We're not telling you that you have to have a patient-centered medical home or an episodic payment or a bundled payment. All we're saying is you can't use fee-for-service. Because there are folks that are a lot smarter than me and my colleagues that do this every day. And they're going to decide. We want them to continue to innovate and continue to be able to do some interesting things. We just don't want them to do it in a way that only rewards you for being sick. We also created a predictable cost growth goal. So we set our goal at potential gross state product. Eases out the peaks and valleys of the market. You cannot grow any more than potential gross state product. 5 years from now, you can't not grow any more than potential gross state product minus 0.5%. What that is going to do is it is actually going to begin to bend that curve. It has to bend the curve. There's no other way. It will bend the curve in terms of squeezing some of that third of waste and inefficiency that is in our $66 billion in Massachusetts. Now, folks will always say, well, that's going to mean jobs. Well, you know, it might. Might mean jobs. But the reality is, at least in Massachusetts, and I know this is different for each individual state, we have too many hospital beds. We just don't need the hospitals we have. And there was a report that came out yesterday. Executives at hospitals are still paid based on the number of heads that they have in beds. So the system is not aligned in that particular way. I want to see 15 hospitals close in Massachusetts. It would be incredibly good. We actually toyed with the idea of paying hospitals to have a low sentence, similar to what we do in court. We said, give you a few years to actually put yourself out of business. But ultimately, there will be other jobs. There will be home health care. There will be tech jobs. There will be other things in healthcare, in telemedicine. There will be things that we will create when we get out of the way that we used to think. And that's what we need to begin to think about. Now, how does that involve Medicaid? Well, government's got to move first. We can't ask the commercial market to do anything that we don't do and that we're not willing to do ourselves. So we say 25% of the members by this July, 50% by next July, 80% by 2015. So essentially by July of 2015, fee-for-service medicine in our Medicaid program will be gone. Now, this presents a little bit of a problem with our dual population. We have to, at some point, work with the federal government on understanding that fee-for-service doesn't work when you have the ability in Medicare to opt out anytime you want into fee-for-service. You also have the ability to opt out and change providers. Those don't make sense. It doesn't make sense if a provider invests in you to be healthy if you then have the ability to leave them at any time. You need time to have that provider be able to invest in you and see the long-term returns of keeping you healthy. The other thing we did in Medicaid is, we all know that the big problem is money, right? It's rates. So we set aside $20 million to increase rates on Medicaid. We're at about 61 cents or 62 cents on the dollar in Massachusetts on the Medicare dollar. And it's a huge problem. That ultimately is the underfunding that is just making it very difficult for anyone that deals with the Medicaid population to make any money. But ultimately, we think, or we predict certainly, that as you move towards alternative payment methodologies and you work in all of the other things, the other tools that we've given you in the toolbox, the money will be available to begin to raise rates, but only to raise rates for those that are showing that they're able to compete in this market. Mass health initiatives. So again, what are the choices? So what have they decided to do now that we've given them these tools? They've decided to do patient-centered medical home initiative, which is an initiative that I think a lot of states are obviously moving towards. Primary care payment reform. We have decided to keep both our primary care program and our MC program in place. We chose not to go one direction or the other. It is still a matter of the patient to be able to choose there. There are some that have wanted to go all MCO, and there are some that have wanted to go all primary care, which has a little bit of a behavioral health, better behavioral health program. But ultimately, we said that isn't the issue. The issue is really how we pay and how we coordinate their care, not who takes care of them. Pediatric asthma bundle payment. This is a really, really exciting program. We're doing this in partnership with Children's Hospital and others. You know, there's a whole problem with the way we pay in fee-for-service medicine with the children and elderly that happens in the summer, right? There's no way to buy a family a vacuum cleaner in the way that our healthcare is set up. Yet if you buy a family in an urban area a vacuum cleaner, you may reduce asthma in that household by some percentage. That's what this bundle payment pilot is showing. You buy an elderly person an air conditioner, which there's no way to reimburse right now in our current system. You may reduce one readmission over the course of the summer, which pays 10 times over the cost of that air conditioner or the cost of that vacuum cleaner. This is an exciting program that we're seeing some great results with. And then the transformation initiative that I talked about before. Mass Health is also doing things that all of us are doing to become compliant with the ACA, or all of us that have chosen to become compliant. We have a duals demonstration project, which I talked about a little bit and why that's challenging to us. We're a little bit more generous in Mass Health, so we have to have a state wrap plan that follows the Medicaid expansion program. Money follows the person is obviously happening. We already had our exchanges set up. So we are in pretty good shape because some of what has been done in the ACA, as you know, is following our 2006 law that was done in Massachusetts. Now, we just finished our Medicaid Delivery Model Advisory Committee. So we looked at our law from last year, and we actually voted on the recommendations yesterday. So what do we need to do? And these may seem very simple, but they're really not. The problem with quality, and I know we talked about quality in Tennessee and others, and one of the quality measures that we all use is patient experience. Well, if you cut off the wrong leg, but you felt really good about it and you had a good meal while you were there, sometimes you feel good about the experience, but not necessarily the quality that we want to be measuring. Walk into any hospital anywhere in the country, there's a banner in the lobby. That banner says something. It says best in something. Just look the next time you're there. Our real issue with quality is we're just not agreeing to an apples-to-apples comparison about how to measure quality. So we really don't know whether our teaching hospitals are better than our community hospitals or who's doing well and how to measure that. So we really have to get on the same page in terms of what we measure for quality. Cost and adequate funding. Obviously, if we're not investing in the infrastructure of all of our Medicaid programs, I mean, just look at some of the computer systems that those that work in our Medicaid programs are using. We're in the Stone Age. If we don't invest in some infrastructure, we're not going to get there. Obviously, access to medical and behavioral health care. This is a big issue. We're trying to move to an all-integrated system. Behavioral health is integrate. Anybody that sets up an ACO in Massachusetts has to have behavioral health as an integrated component of it, and we have to see whether or not we can begin to see how to handle behavioral health in a way that becomes part of your primary care. So we've allowed behavioral health providers to become primary care providers for setting up medical homes. So you could have a behavioral health medical home. If somebody gets their primary care at a behavioral health center or a substance abuse center, that's where they present most, then why can't that be their medical home? And they get their traditional primary care someplace else as a contracted service. So we're looking at different things to do there. Data and transparency, I already talked about that. Some folks want to do better, they just can't get the information. If we're not giving our providers information in real time as fast as we can, they can't improve. And what happens now is there's a huge lag between what's happening within any provider network or any physician network and then what's happening at Mass Health or at Medicaid getting the information back to them. So we have to do much better job of that. And then obviously I talked a lot about the expansion of alternative payment methodologies. Where do the savings come from? And again, Darren was absolutely right when he says there's wild speculation about what might cost and so you try to be as conservative as you can, but you also, certainly as an elected official, we'd like to be a little optimistic about it. So we don't necessarily use all the higher numbers, but we like to look at where we can save money. Obviously inpatient is huge. As I mentioned, certainly in Massachusetts there's too many hospital beds, so one-day admissions, one-day surgical admissions, there's real savings there. Readmissions and behavioral health, there's some savings. Non-inpatient though, these areas are actually pretty, again, the low-hanging fruit that we should be doing immediately. The emergency department is one we all know. There's just, there's just absolutely no way, and I know that we have friends from CVS who are good enough to be sponsors here today. Some of the limited service clinic stuff that's happening is really innovative stuff. If at 9 o'clock you can go to a limited service clinic at CVS Caremark and be out in 15 minutes, or go to the emergency room for 4 hours, what are we going to choose? It's just about getting access. So it's keeping people out of the ED. Lab it is overutilized. We just had a Medicaid study. It's wildly overutilized, particularly with drug screenings in Massachusetts. High-tech imaging is one that we have talked about before. And pharmacy is one. We I believe, still lead the nation in terms of our use of generics, so it's not a huge issue for us, which is why it's a small savings number. Now, a couple of final points before I move on, and that is that when we approach this, and some of you heard me say this before, when I got named to to be chair of the House committee, we had just had twins, and one of my twins was real sick, and I spent 94 nights in the hospital. So I went from being a policy person, right, to someone who cared about this personally. And so when I was at Brigham and Women's Hospital in Boston, the most expensive hospital, or the second most expensive hospital in the world, and my wife gave birth to twins, and I walked with one twin, Miles, over the bridge to Children's Hospital in Boston, the most expensive hospital in the world. I, like all of you, did not say, what does this cost, right? Or should I get him to a community hospital so I can save money? Or is there some other low-cost provider that's available? I said, I want it now. I want whatever, I don't care what it costs, and get him the help that he needs. But in living there, it became my home. In living there, you begin to see what works and what doesn't work, right? And certainly, some of you that work in medicine on a day-to-day basis, certainly Kelly can tell us even better what works and what doesn't work. But the inefficiencies are extraordinary. So what I did then after that experience is I visited 64 of the 69 hospitals in Massachusetts and just watched. What works, what doesn't work, how do we create an environment where our community hospitals can survive first and then thrive, but we also have those best in the world teaching hospitals when we need them. So when we wrote this legislation and subsequently created the Medicaid regulations, we did so in a sense that understanding that one, when we need our health care, we want the best. Two, we are oftentimes in the Medicaid population dealing with folks that are non-compliant, which makes it very, very difficult. So you have to have the incentives in that regard on the provider side. And three, how do we make sure that nothing we do is going to be perceived as rationing, being perceived as a capitation in a way, so that the rationing or capitation of a global payment makes sense in terms of incenting you and your provider to make you healthier. And if you save money in the process, we predict our family plans within 3 years will go down $2,000 per year, which is real money. Now everyone says, well, 15 years, we're going to save $100 billion. Those numbers are just, those are ridiculous. But $2,000 in a person's pocket in a family plan 3 years from now is real money. So, so thank you. I would be remiss if I didn't mention my co-chairs here. I have been blessed, the healthcare committee. I have had 2 extraordinary co-chairs. My first, as many of you probably know, Senator Dick Moore has been around CSG and NCSL for years. He was a great colleague and then became a great friend and mentor to me. And Jimmy Walsh is here, my co-chair now, who was a great friend and now is my co-chair. So I have been blessed, and I know that all of you know when you chair a committee, you're only as good as your co-chair. So it's great when the House and the Senate work so well together. So thank you very much, and I'll take any questions after the panel.